All right. And the reason why we have you do all these breakdown in groups and running a note together, that's one of the things that we have heard on the second year we met, that students have been somewhat deficient on how to write a note, if you will. So we're trying to engage you. And the thing is, you take this class, and then you have another maybe a year before you do your behavioral rehabilitation. So by the way, you on that. So at least you'll have PowerPoint and things where you can go back on when you need behavioral health. Does that make sense? All right. So psychotic disorders. Yes? Yes. All right. So psychosis is really not a disease. That's the main thing to remember. Psychosis is a state of somebody, right? So you can say cough. Right? Cough is really not a disease itself. Cough is associated with something else. You see chest, pneumonia, itis, but cough itself is not a disease. That makes sense? Same thing with psychosis. Psychosis is not a disease on itself, associated with some other medical condition. That makes sense? All right. So let's think about this woman. 20-year-old woman was brought to the emergency room by the police after she started screaming at Starbucks, then threw coffee to the barista. Anybody from DC? Not my name. I'll keep going. In the emergency room, she stated, "I need to be taken to jail. I think I contaminated someone with the virus. I need to go to jail. Don't get near me. I will make you sick." So they get blood work. WBC is slightly elevated. Why would the WBC go up on a patient like this? Why? It's a very simple answer. Say again. Close. So people who go through trauma, physical trauma, or they just get really excited, there's going to be a leukomoid reaction where the white blood cells inside your vasculature who are adhered inside the blood vessels become loose because they're thinking something's happening. It might be getting ready for a chemical reaction. So you see a lot of crazy people that get admitted to the hospital with leukocytosis. It's not because they have an infection, it's because they have this leukomoid reaction from trauma and agitation. Does that make sense? All right. Toxic, Utox is negative. Blood pressure 135/78. Heart rate is 82. Regular physical exam is unremarkable. Patient is fully oriented and has not had any waxing or waning level of consciousness. So she's just belligerent. Yes. Yes.
When you say physical exam is unremarkable, what physical exam is it?
That's a great question. What would you do? What kind of physical exam findings would you want to make sure you don't encounter? Say again? Neuro exam, excellent. What else? Heart and lungs. Why? Sure, good one anyway. So, elderly patient with pneumonia, they can get crazy, right? What else? Blood sugar. Yes. What else?
Check your urine.
Check your urine. Infection. What else? Drug screen negative. Good job. Physical exam, you want to make sure she doesn't have any rashes, right? Is this patient going to have encephalitis, some sort of meningitis, getting crazy, loopy on me? Does she have meningitis? Does she have any trauma? Does she have a big goose egg in her head? You know, so very good question. All right. She appears psychotic, right? Like saying the patient has a cough. Saying she appears psychotic. She's crazy, but why is she crazy? You don't know, right? So you have to think about differentials. Cast a wide net, right? In terms of the psychiatry of this, you worry about mood disorder with psychotic features. And we'll talk about this a little bit in the lecture. But people who are really, really, really depressed or really, really, really manic can get psychotic. Okay? People who are very manic start doing crazy stuff. They will tell you, God told me to do it. You know, or you know, I know I can fly, so I can do it. You know, so they, in that sense, they're super manic and having hallucinations, delusions. If you're profoundly depressed, you can also have the same delusions or hallucinations. Schizophrenia and schizophrenia. How do you say that wrong? Schizophreniform. Yeah. All right. Disorder. Um, we'll talk about this a little later. Substance abuse, psychotic disorder. Are you doing drugs? Are you doing meth? What's going on with you? Do you have a delusional disorder? A psychotic disorder to general medical condition. Does the patient have any endocrine, infectious process that's causing her psychosis? Shared psychotic disorder is a person thinks that it's cool to be crazy, so you just go around acting like they're crazy, but they're not crazy. That makes sense? It's almost like conversion-ish disorder. And then the most popular psychotic diagnosis in the world, psychotic disorder non-specific. That is what almost 95% of the people who are psychotic will get diagnosed with. You just crazy. Okay? So, other diagnoses can masquerade psychotic illness. Delirium is when you lose touch with reality, but it's something that is reversible, right? So the patient who has opening of the UTI gets admitted, they start sundowning, they're delirious, they start infected. Once they get better, they get hydrated, they're back to normal, right? Parent personality disorder and schizotypal personality disorder can dance very near the edge of psychosis. We'll talk about that in a little bit. And OCD at times, obsessions can be difficult to discern psychosis. Who knows who John Starks is? Basketball. Right. Just holding it. So John Starks used to be a guard. He used to play for the New York Knicks back in the 80s. And he had OCD, like really bad. Therefore, he was a great shooter. He used to stay in the gym hours and hours to do a shot just right. His big psychosis was that when his shoes became untied, he would stop the game and he would tie the shoes over and over and over and over and over. Get it? Some people say, crazy? No, he's not bad OCD. So OCD can masquerade. Motor personality disorders, when dysregulated, motor personality disorder patient can appear paranoid and think that they hear people talking trash about them. So these are really hard people to manage and to get better. And on the extreme, they can appear to be psychotic and sort of lose touch with reality. So how do you identify diagnosis of psychosis, right? The first thing you should do is make sure that you capture anything that you can taste. So it's the blood sugar, get the blood sugar. The patient has a big Goomba on their head, get a CAT scan. If the patient has encephalitis, do an LP, right? So all those things you try to investigate first before you start doing psychiatric diagnosis. But once you have ruled all those out, then you can start thinking, is psychotic illness only when the mood is present, right? You get crazy only when you're really depressed or really happy, that's a distinct entity. So the patient has a medical condition that can cause psychosis, right? You have Parkinson's disease, you have end-stage brain tumor, so on and so forth. The patient using drugs, and the person goes through PT, right? Somebody would abruptly stop drinking, they can go through PTs, and they can have hallucinations, delusions, seizures, all that good stuff. Does the patient have prominent negative symptoms? So we'll talk about negative versus positive symptoms of psychosis, schizophrenia. Negative symptoms are those that take away from your personality, right? So if you're usually a normal, happy person, you're not super depressed. If you think that people are against you, that's kind of a negative symptoms. But we'll talk about this in a little while. Is the patient delusional or psychotic actively right now? And what is the nature of the psychotic symptoms? Are they mood congruent? Are they associated with depression? Or are they incongruent? They just happen without any association with mood changes. Okay? And I'm going to tell you, don't try to compartmentalize these things, because in real life, it's a big bowl of wax, of spaghetti. It's really hard to piece out what's happening. And for test questions, you'll know what we're asking. We're not going to make it convoluted. But in real life, it's really hard to tell whether somebody is having a conversion disorder, being somatic, or they just be report on the sun. So it's really hard to dissect these things. All right, hallucinations. False sensory perceptions associated with real external stimuli. They did, I think it was in Arizona. In Arizona, they went to a group home where they have a lot of schizophrenic patients, and they told them to write or draw what you see or hear, right? And they actually did that, and they took that and they put it in a virtual reality program. So they had providers do this thing, where they would actually see and hear what they were seeing. And some of the things that they portray were multiple voices, overlapping, criticizing, the poster that would change its text, obscenities, newspaper that would change the word dad, the floor that would fall away, books and shelves with titles of fascism, and so it can be anything sensory that is just not real. The illusions are a bit different. They're false beliefs based on correct images of external reality. This is the person that says, I am Julia Roberts' husband. You know, and she knows it, I know it, but I'm her husband, right? The person might say, I'm the person that needs to be in the White House. I'm the person that can touch the sun. All this crazy stuff that you know it's not true, right? And always you got to keep in mind cultural norms, okay? Some cultures, they might have things that for you might sound crazy, but for them might be just regular cultural things. This guy's delusional, I think. Where'd he go? Where is it? Where is it, Ram? Wait a minute. Okay, here he goes. All right. Thanks, man.
Delusions. These are false beliefs which persist in spite of incontrovertible evidence to the contrary, and which are out of harmony with individuals' religious, cultural, and social background. In this clip you'll see a patient with thought block and persecutory delusions being interviewed, demonstrating his fixed, false beliefs.
It's the government.
Right.
They don't want me to.
Can you remember I was making a comment about your thoughts seem to sometimes you seem to stop speaking sometimes.
Yeah.
You were telling me about the government.
The government.
And then again your thoughts seem to stop.
Because I was about to tell you.
About to tell me what? What were you about?
The government takes my thoughts away.
Right.
If I'm about to tell somebody, quite often, they will take them away.
But why would the government want to take your thoughts? What reason?
Well, it's because of me, because of who I am, what I know. They don't want me to tell anybody.
And what is it that you know, and what is it?
Well, it's the politics, you see. I'm his brother.
You're whose brother?
Prime Minister's.
Right. And is it because you're the Prime Minister's brother that they take your thoughts? Well, how do they take? How can somebody take people's thoughts?
It's a transmitter. They've got a transmitter and it's tuned in to my brainwaves. Once my brainwaves hit the right signal, which shows them I'm about to tell someone, I'll just cut it off.
Right. How long have they been doing this for?
It's been a couple of months now.
All right. So he's thinking his thoughts are being taken away. So I got Dorothy Day to admit because he thought that once he had something over his head, he could not some kind of fault. So he would like go from gas station to in the fridge, and smoke out a big brick on his head, need to go and talk to the public, something like that, right? Mood congruent delusions, hallucinations, persistent with themes, depressed, which is personal inequality, guilt, deceit, death, pressure, punishments, manic word, mood themes, word, power, knowledge, specialized anxiety. So this is when you become supremely depressed or supremely manic, and you start thinking crazy stuff, right? I deserve to die because I'm a horrible person, and everybody hates me. So that would be a mood congruent delusion. All right, you okay so far? All right. So mood disorder psychiatric features. The major depressive disorders, and then you go crazy, basically. Bipolar disorders, manic with mixed, and of course, schizoaffective disorders, you'll talk about a little bit. But think about bipolar extremes, that are going crazy. That's what we're talking about here. So major depressive disorder, patient meets the criteria for major depressive episode. Also, you see hallucinations, it's delusion about their state. You have intense suicidal ideation. It's a definite break from reality. Okay, and can you see how hard is this to dissect? I mean, is the patient just making this up? You know, are they manipulating you? Do they want something? You know, this is not an easy task to figure out. Are you depressed, number one? Or are you psychotic, number one? What is your deal, right? So, does not have psychotic symptoms or types of type. So, when they feel okay, they're not psychotic. That's a clue. And psychotic features occur in about almost 20% of patients who are diagnosed with major depressive disorders. Have you seen these guys, Brendan? Have you seen these guys? No,
Many with psychotic features. I had one person in my year that I was doing the internship that had psychotic features, but I'm sure that Jason saw.
Jess, you see anything like this?
I think it's become more common for us schizophrenia and schizoaffective disorder. Some did see a lot of prevalence of like made NBD, but we did have some patients with NBD, but they didn't have the psychotic features necessarily. And then sometimes they would be diagnosed that it would be like stress-induced transient psychosis with well-known personality disorder.
Nice cocktail there.
Huh?
Nice cocktail.
Yeah.
You know? All right, so you got to give them meds, right? Once you figure out there's nothing physically wrong with you per se, but you have a psychiatric illness, you want to try to get them back to reality, right? So antidepressants, profoundly depressed, antipsychotics as well, right? If you're depressed and seeing stuff, well, maybe a little Giodan, a little Haldol, something to kind of break them. Antidepressant, antipsychotic drug treatment, a bit better than monotherapy in studies, and you're going to have a whole second form on this, so I'm not going to go into that. ECT, we talked about briefly in one of the lectures that we did. This is very, very effective for depression, for schizophrenia, and locally they do it at UNC. I think that's the only place that locally does ECT. But it works well. I mean, in 1950s, they used to do insulin shock therapy. You heard about this? They used to have these schizophrenics, and they would give them huge doses of insulin. So what would happen to the blood sugar? Drop. And if they didn't die, the brain seemed to reset, recalibrate. And they used to call that insulin shock therapy. If you want to read something a little weird or not, read that. So, ACT in non-psychotic depressions, they just plain old depressed people, did really well in patients that were suffering from this. And patients with psychotic depression compared with 83% remission in patients with non-psychotic depression. ECT treatment with bilateral or right electroconfiguration can be superior in combination. Don't worry about that. If you end up doing ECT, they might want to know how you can do it. Well, because electro, you can have it. All right. Bipolar disorder, remember, is when you're really manic, right? You can get psychotic with this as well. Estimated happens to about a quarter of all bipolar 1 patients. Okay? Then this is when they get really, really dangerous because they start hearing voices like, yeah, go ahead. And you can go, go to 7-Eleven and get some money, go back to the casino, or you can start hearing all this other stuff. have stress, people who are depressed, manic bipolar. Do you hear any voices? Tell me what you think your role here is today, to make sure they're not having any delusions or hallucinations. So again, the treatment is give a mood stabilizer, SSRI, antipsychotic. If the patient is mixed or not responding to meds, ECT works. Keep in mind that catatonia is most commonly with bipolar disorder. Cortisol treatment for benzodiazepines is not diazepines for catatonia. So people who are having these fake seizures or people who become catatonic, sometimes you can break them with Ativan, Valium, usually higher doses though. Usually we use for somebody who's having anxiety. And this is what catatonia looks like. There you go.
Catatonia. Catatonia is a state of increased muscle tone at rest, which is abolished by voluntary activities and therefore distinguished from extrapyramidal side effects.
Is that
In
too
these
low?
clips you'll see a variety of forms of catatonia demonstrated by a role player being examined by...
Sorry guys. Let me get a little lower, higher.
It's all good. No worries. Just falling apart over here.
Alright. Okay, I guess it's just the way it is.
Catatonia. Catatonia is a state of increased muscle tone at rest, which is abolished by voluntary activities and therefore distinguished from extrapyramidal side effects. In these clips you'll see a variety of forms of catatonia demonstrated by a role player being examined by a psychiatrist. This clip shows force grasping, where a patient is unable to comply with instructions to resist a preferred handshake. Characteristically, the interviewer has difficulty getting his hand away.
Just want to move your arms around a little bit. Is that okay? Okay. Okay, just leave go. Just relax a second. What I'm going to do, I'm going to put my hand out, but I don't want you to shake it. Okay, leave go. Think carefully about what I'm asking you to do. When I put my hand out, as though I'm going to shake your hand, don't take it. I do not want you to shake my hand this time. Okay. Okay, that's fine. Just try and relax for a second.
In this clip, waxy flexibility is demonstrated when a patient's limbs are placed in an unusual position, where they remain for a sustained period.
I'm just going to move your arms gently. You said that you feel that there's something not quite right. You're having some difficulty explaining that.
The patient in this clip is displaying opposition, resisting all attempts by the examining doctor to move his arm.
I'm just going to move your arm gently. Just let it come with me. Okay? Okay, that's fine. That's fine. I'll try and pop it down this way now. Okay. Okay, that's fine.
A more intense form of opposition is negativism, where the patient actively resists all attempts to make contact and also, in this clip, displays aversion by turning away from the examining doctor.
I'd like you to just shake my hand. Okay. And shake my hand, Peter. Okay. We'll leave that for now.
So the waxy catatonia, where we kind of put some those like that, and they'll stay there. They'll stay there for hours on end. Somebody breaks them or something. It's for the most part. Yeah. Well, once you get medicated, they do really well. Yes, ma'am.
I was gonna say, are those just for bipolar? Is that a hallmark of just a bipolar treatment, or what?
Schizophrenia.
Schizophrenia. Oh.
I think the slides have something about
Oh, really?
bipolar, but
Yeah.
it's really, it used to be that there was schizophrenia catatonic type, where they, it's the Al and Jason.
Yeah, I think it's what
Schizophrenia.
schizophrenia. Yeah. Thank you. Well, yeah, those things are, once you get medicated, they do okay. So, Beautiful Mind, that's what I'm movie, I'm sure, right? And it's something to remember that type, it's kind of interesting, the type of voices that we hear in the Western world are more negative and depressing, and people like in Africa, they hear positive requests from family members or spirits. So again, it's a cultural sort of difference. All right, so we talk about positive symptoms. We talk about things that are going to make you change, like they're usually not there in a normal mind. So hallucinations, delusions, bizarre behavior, thought, speech disorders, schizophrenic. Sometimes they get talking really quick, and you can't really understand what they're saying. It's just a mumble that they're having. Because negative symptoms are the ones that are crippling your personality, who you are, affect flattening. Have you ever see a schizophrenic when they're treated? They're just very, very flat, and they don't really react very well to jokes. They're just not very emotional. Alogia, they have poverty of speech. They don't talk a lot. Okay, which makes them scary when you look at it. They're kind of quiet and withdrawn and kind of flat. And then apathy, they just don't really care. You tell them, curfews at night, you gotta go to bed. They're like, just go to bed. And then anhedonia, of course, they have no pleasure in anything. All right, schizophrenia. So, diagnosis: 2 or more of the following present for at least 1 month. Delusions, hallucinations, disorganized speech. I'm supposed to put a link there, but sorry. Disorganized speech, the person just talking, you can't understand what they're saying. Total disorganized or catatonic behavior, and then the negative symptoms like we just discussed. All right. Only one criteria is needed. If delusions, bizarre, consists of a voice keeping running commentary or 2 voices talking to each other, most cause significant social dysfunction, and it continues to serve for more than 6 months. If it's less than 6 months, everybody who you think has schizophrenia, the first get diagnosed with schizophrenia, because you have to meet the 6-month criteria to get forward to schizophrenia. Does that make sense? So you have different types. You have the paranoid, the thing, the FBI is following me. You have the disorganized speech, behavior, right, inappropriate old present. They just don't have personality. They're not behaving like the rest of the population. And then catatonic, they're the ones that are just not moving, resist movement. They can have peculiar movement. They're just a motor problem. So 1 to 2% population have it. It's hereditary in nature. It runs in families, if you will. Onset, usually if you're going to get schizophrenia happens when you're late teens, early 20s. I read somewhere like 22 is the age that most people flip over to get into schizophrenia. Only 10% of cases have been reported over 45 years of age. And again, those are the ones you think, are you with schizophrenia or are you doing some other thing with here, you know? So, and again, the presence of a program with schizophrenia significantly increases the prevalence of schizophrenia. All that says that it runs in your family. Okay? I used to know a doctor and his wife, and they both have schizophrenia in their family, and it seems like they skipped their, skipped them, so they never had kids because they were worried about having kids that were schizophrenic. So it doesn't happen every time, but you have a higher incidence if it runs in your family. Okay. So 50% schizophrenia risk are genetic, 40-50% concordance. They're estimated. All 50% are unidentified preventable factors, including year exposure. There's some contention about how much of the environment or where you're born, where you're raised, contribute to you becoming schizophrenic. Some studies say that people who live in highly stressed countries will tip a lot easier because they're already hyperstimulated, they're stressed, they're anxious. So, versus living in a nice, loving environment, it doesn't really, you can still get schizophrenic. All right. So, pathophysiology, it's a lot of big words here. But what it means is this. When you're little and you reach for a hot plate, what do? Right? So you start making these pathways in your brain, these neural pathways. And over time, you develop this pathway that you don't have to think about. It's hot. You draw it, right? People who have schizophrenia, they don't make those pathways easy like any other people, right? Like if you are a person who likes to go on roller coasters, right? The roller coasters make you anxious, right? So you develop a pathway like anxiety associated with roller coasters. Schizophrenics will not develop that pathway ever. So what happens is the brain starts making pathways to fill in the gaps. Okay? Why it starts making things like you start hearing blue, you start, your sensory gets jumbled, if you will. And they don't really know exactly why, but one of the theories is like your brain is sort of trying to fill in the gaps because you were not able to form those tracks, the things that people usually form. Does that confuse you? Okay. That's kind of the way I remember it, they explained it to me. All right. So schizophrenics tend to be suffer from addiction as well. Almost half of them will have some sort of drug or alcohol addiction. They also have alcohol or drug abuse, sort of almost 5 times greater for people with schizophrenia than the rest of the population. So negative symptoms seems to be more debilitating. If you don't have any body to get better, if you have any anhedonia, if you don't react to stuff, you tell your psychiatrist, and it makes therapy very challenging. 90% do not return to pre-illness lab level, which is sad. 10% die by suicide. All right, and generally, you'll have a different outcome, if you will. Okay, a third of the people will have severe social vocational implications that will not be able to live in society. They'll have to be one-on-one care, locked in a state hospital the rest of their lives. They will not be able to function. About a third will be able to be medicated and be able to hold simple jobs, simple things, and live okay. And then a third will be able to have a pretty good life, hold decent jobs, and be, as long as they take their medicine, etc. Is that what you got, Jason? About that? Is that what you break down when you work that?
So I worked with very local individuals. We had a program that managed every aspect of their life, so that they remain in the community. It's the most extreme type of care, I guess, aside from the education.
So you saw the ones that were needed. care.
So we basically, when the first 1/3 was not inpatient for some sort of psychotic break, they would come back out, we would take them to the inpatient unit, collaborate with them, and they would get stabilized to some degree, and then we would try to manage them, make sure they take their meds, do pill boxes, injections, counseling, and then we just monitor them so frequently that when they started to decompensate, we would put them back in. It's kind of like this revolving door, but it was cheaper to pay for our program than keep them inpatient forever.
Right. Yeah. And you see a lot of middle house, group homes. Yeah.
The initial presentation of schizophrenia, you said it's around age 22, average. Is it a gradual presentation, or is it like a psychotic break? They have or does it depend? Do you know?
From what I heard, it's gradual. Is that what you got?
I think it's like we see the deterioration of a lot of the social stuff. They might have been weird in school, or they didn't isolate, antisocial, or they just never fit in. But then it was usually marked by a psychotic break. They would be that like lose touch with reality, and their families like what's going on, and so that would be sort of earlier on. I would see them when they were 40, 45, when they've had multiple psychotic breaks, and they've basically eroded everything that they ever had. All their families just like, we can't deal with them. We don't know what to do. We give up. Yeah, I mean,
A lot of work. Usually, when I talk to the psych guys, they said that, like Jason said, they would have some sort of crisis that would bring him in, and then once they got the history from the family, then they would tell you about the negative symptoms, like, you continue wrong, go out anymore, and then they would all get wrong. So that's been going on for more than 6 months, ain't already on my leg definition. Does that make sense? Right?
and with the negative and positive symptoms too, it's like the negative symptoms are more of the depression, like you said, the anhedonia. Positive symptoms, we always said, were the fun symptoms.
Yeah.
That's when they're like just the getting out there, the psychosis, stuff like that.
So, Mr. Ben, I actually have a question about those. Do people just kind of cycle through these positive and negatives? Or how does like some people have more negative, like have more negative returns, while another person might be more probably positive, might be positive?
But when you mentioned after treatment, a lot of times what happens is if the medications block their, I guess it's their, is it not, it's a GABA, or it's one of the, like we learned about partial antagonists, and like, so what happens is they'll be treated and it will block the influx of dopamine or whichever one causes the hallucinations, and so then they'll present flat. They're like, their brain's been shut off, so those receptors have been depressed so much that they have a lot of the negative symptoms. But then, as far as like cycling back and forth, I think when we saw people who would manage their meds, like we would give them an injectable, which we'll probably learn about, like the Vegas Extendus and Abilify and Antenna, like a once-a-month shot. But as long as they stayed on their meds, their symptoms were manageable. But they, I think when treated, you'll see like the flat symptoms, but before you can see both, I guess, better.
Yeah. And the thing is, a lot of times you treat for the positive symptoms, which those are the ones that you really get in control, basically. But the negative symptoms sort of try to give it a sense of, talk about it. We had the cafeteria open at Dick's was the cleanest cafeteria. Yes, sir. It was the cleanest cafeteria in North Carolina. Because there had nothing but OCD people working in there. you could eat up the floor, So there was this one girl, this one patient, and they have patients work there, and she had beautiful eyes, she was young, vibrant, but flat, absolutely flat. So we thought either meds are causing her flat affect or she issues. Right. So my attending and I would go down and grab a hot dog and try to make her laugh. And we come up with the corniest jokes and nothing. And I was like, this in the street, nothing, But so yeah, flat affect is one of the things that mostly will suffer more time than the positives. The positives are the ones that you treat right away and try to control.
They both can coexist.
Yes.
I mean, I guess that, because I've had some that were very flat, and when you're talking to them, they don't have any, you're like, they have no personality.
Right.
There's just no personality, but she was very flat and reserved, and she would respond in quick pressure speech, she would respond really quick, and then, but she still had this ongoing dialogue with her dead father who, like, talked about how she was a horrible person, so it was,
Yeah. Brandon?
And I was gonna say, I was in Gainesville studying for these, a lot of these people who aren't as, or a little bit higher functioning, but still that consider environmental hospitalization, they can have episodes that are brought on by like their environment and stuff. And one of the, I guess, supportive things that people would do is they would, different organizations would give out things like really old Bluetooth headsets that you would transfer to phone, and they would wear them around, so you'd be sitting on the bus and that person was talking to themselves, because when someone is staring at them and looking at them, that can make it worse, and that can make them to like.
Feel with age issues with the cell
So
phone.
they'll put a Bluetooth, they won't even have a cell phone in their pocket, but if they respond to voices, then
Right.
it doesn't trigger as much, so sometimes that can help with sort of the higher functioning, is to kind of just treat the environment that like there's lots of education police and stuff like that to kind of manage people, because they can be set off more from
Yeah.
people around them responding to it.
Have you ever seen one when they're actively hallucinating or having delusions? You know what's going on. Are you on something? They get arrested because you're acting weird. Man, that's a problem.
And movies like teach us like, these people are really dangerous, but the vast majority of people with mental illnesses aren't
Right.
dangerous. And
Right.
people that just see someone talking to themselves, they think that they're in trouble, they're in danger.
Right.
And it's very rarely the case that someone's
Mhm.
not trying to harm you.
Right.
when you see it, you'll know it.
Yeah.
I mean, they're talking like, I don't want to do that. I'm not going to do that. No. And they're like, I mean, they're just like throwing their hands up, no. And they'll be like sitting on their hands and making weird contortions, and I mean, it's very.
They're not here.
Yeah.
They love it. This is an artist in the 20th century that, as he became more schizophrenic, his drawings reflected this sort of detached with reality. I like the last one better, I think. Third one? This one? I don't know. I like it. Let's take a turning point. No, I'm just kidding. All right. So, positive symptoms respond better than negative symptoms. I mean, in the ear when they come to a client, you know they're schizophrenic, they're decompensating. You can give them a dose of Haldol, Geodon, and within a few hours, they're pretty good. Okay. A typical antipsychotics used first to reduce risk of tardive dyskinesia, can have weight gain, metabolic syndrome, and include elevated lipids in type 2 diabetes. Smoking helped their TDs, which is some of our nicotinic receptor blockade, whatever. But they would need to smoke once a day, and it was just awful because it made their life better not to have the TD. They were not supposed to. My stomach much. Last story. So they're not supposed to have cigarettes, because they're crazy and the fire hazard, all the stuff. So one day we're going into the bar end of the unit, and this door, the doors are open. The last door is the open window, and the unit is locked. I mean, there's smoke everywhere. I'm like, oh my. We go in there, say had a cute women's ward, so it's just frantic, water, they're all kicking back. All of them, all 30 of them, the solarium. That's Dr. Man. Dr. Man, should we stop this? Are you crazy? Let them have their cigarette, be done with it, because you really seem to have the calming and the side effects, but anyway, okay.
Mr. Sorry. Can you explain what that tardive dyskinesia is really?
I'll try. So it causes, they're called EPS, extra peripheral side effects, and it causes some pill balling, things sometimes, some lip smacking. What's another one? Tremor.
Is that in response to
So it is. Right. So yeah. Does that make sense?
Is that in response to treatment?
Yes.
So what is
It's
it?
a side effect.
From the first generation antipsychotics, it can cause tardive dyskinesia. So something that can come from too much medication or so.
Yeah. But, alright. So like Jason said, risk of tardive approximately 3 to 5% a year for a typical antipsychotic. And the other thing that can cause these things, I knew this, we have to check a CBC on them every 3 months. Check for agonocytosis, check an EKG for long QT syndrome, and all this stuff. So they have a whole bunch of side effects. You have to be careful with them. Risk of dystonic reaction highest in the young males. Okay? Alright, schizoaffective. This is crazy with mood. Okay? It's a major depressive episode or mixed episode while having psychotic schizophrenic symptoms. Okay, that's the difference. Periods where delusions or hallucinations are present for more than 2 weeks with prominent mood symptoms. Symptoms meet criteria for mood disorder are present for a substantial portion of the illness, about almost 10% lifetime. Does that make sense? Yes.
How do you distinguish this from bipolar with psychosis?
The duration, so the psychosis has to be, and delusions have to exist without the delusion. So
Psychosis existing
it's like
without mood.
schizophrenia
Actually,
with
Yeah, Jason.
this is just what I did for years.
I know. Hey, I'm leaving on
Whenever
you.
y'all get to cardiology and stuff, I don't know what you're talking
I'm
about.
going to leave you, or we'll leave on Brandon. Put your hand up. We got to get on. Come on, Brandon.
So it just kind of like the way we were talking about this, just kind of think of what causes it. So
Which
what
came
comes
first?
first? Yeah, the chicken or the egg? Is it mood associated with schizophrenia, or is it the other way around?
All right. So schizoaffective disorder is an overlap of psychosis and mood symptoms again. You can have a specified, which is bipolar or depressive. Okay. Maybe I'm over-explaining this, but it's psychosis with mood disorder. And Lori, I mean, in real life, you're crazy, you know.
Well, yeah, because I feel like it would be
Figure
really
out-
hard to do, like, unless you followed a patient, like, you know, Jason probably, like, knew people's school histories, but unless you actually followed a patient for the duration of their
Right.
care, I mean, I feel like it would be really hard to distinguish.
Yeah. Your job in real life as a primary care PA would be make sure you're not going to kill yourself for others, and make sure that you can get adequate treatment and care. You know, but the first time that comes in, you know, mom comes in with her 22-year-old son. You know, he's acting weird. Just very honest with the family. She's going to make sure they're safe, and then refer them to Jason. Then deal
Don't
with it.
send it to me.
All right. All right. So, again, schizoaffective disorder is hard to diagnose, and like Dory pointed out, this was determined which is a mood disorder versus a psychotic disorder going on, and so you trying to figure out which is the predominant feature here: the craziness or the moodness. Okay. Diagnosis only applies to given episodes. Disorder, usually not a lifetime course, but then you kind of you declare themselves over time. They declare themselves what the primary thing is. All right, so affective disorder treatment, antipsychotics is the mainstay. They're all going to need antidepressants, okay? And bipolar, you might have to put them on lithium or some sort of mood stabilizer. All right, let's take 5 minutes, okay? And then we'll start with schizophrenic form. Is that cool? All right. Use your medicine.
No, that's okay. That what he said. What Jason said. He said. It's like, there's no clear cut definition of that. Like you said, they're also lingering because they're addicted to opioids and it's just like right. So then have a yeah.
Yeah, I had a lower vision. I was like missing all the time. So I just checked it. It's too tired. For me, it's. But yeah, what fell earlier, all right. Alright, let's go ahead and get going. Finish on time. So we tell us schizophrenia form is pretty much schizophrenia-like. So this is the temporary diagnosis you might give somebody might be schizophrenic. Because once you hit 6 months, you become like schizophrenia. Okay? So you have again delusions, hallucinations, which are basically schizophrenic sort of presentation. You have to make sure that again that there's no other conditions going on like supermania, depression, substance abuse, medical condition. You do your due diligence, make sure that these are not present. But again, the big key is that at 6 months you will be considered schizophrenic, not schizophrenic. Okay. So the specifiers with that good prognostic features and with good prognostic features, if you have acute onset, confusion or perplexity at the active psychotic episode, you would be more exposure to patient functioning and after the side effect. If you have these basic problems, it's okay. You may not turn to be full schizophrenic. The problem is that you might do this for 3 months, and then you go another couple of years, and you do this, another 3 months, and you're like, well, you never keep it for 6 months to be schizophrenic. So are you really schizophrenic form? Are you acting up? You have conversion disorder? What are you doing? These are guidelines to guide you, but again, in real life, you need to get a little more money. But for the test purposes, 6 months, okay, or less. So, psychoeducation, getting to therapies, for therapy, maintenance of psychotic medication, and usually after better prognosis. Again, once if it doesn't hit 6 months. All right. So this is when you experiment and you start taking alcohol too much, cocaine, amphetamines, cannabis, LSD, all the drugs, and then you start having hallucinations, delusions, acting crazy. Okay? You know what those are. Okay. Substance abuse, induced psychotic disorder. The main thing is you have prominent hallucinations, delusions, you're acting crazy, right? You do your blood testing, your drug screen, try to detect what the substance is. Sometimes the drug test may not detect what they're on, okay? So as of last, I worked in the ER a couple of years ago. We didn't have tests for bath salts in the ER. Did you have it in your ER? No? So bath salts is like super amphetamine, and they come in and it's crazy. Yeah. Okay. So the main thing is it has to be, the psychosis has to be associated with something that they took. Okay. And that is how you get this diagnosis. And again, watch out for withdrawal from alcohol. So if there was no medication that was implicated, you cannot make this diagnosis of substance abuse disorder because there's nothing there, right? Disorder persists more than a month after withdrawal of the substance. The diagnosis is likely less, with the exception of meth. Okay. And this guy is on something. Let me see what he's on.
This is typical reaction to the guy meth. He's not really following you. He doesn't know who you are. Doesn't know what you're doing. He's not functioning real well. I'm actually surprised that he's focusing at all. I'm not. You're absolutely right. I got a job to do right here. You're right. Where are you going?
Freedom.
When? When? When are you going there?
Where'd you plead for me?
I've seen you all cleaned up. What are you doing using again?
I don't know what you're doing with that red pink cat.
It's for taking bad notes. We're just going to leave you in there for a while until you calm down a little bit, okay? He's very, very high on methamphetamines, and it's going to take him quite a while to detox and come down. So he's going to, at some point this evening, crash really hard and sleep for a very long time, and then he'll be a halfway decent human being.
This is pretty good. Okay, so stop while they use it. Quit meth, quit coke, quit whatever thing you're doing. You had this guy in the ER, in Raleigh, Aldo, give him Progenta, give him everything, and he was still like, damn. And for some reason, one of the residents says, check his rectal. I'm thinking, check his rectal. So he had a impregnated tampon over the rectum with meth, I think it was. So it was just constantly giving him little doses of amphetamine. Once we took it out, he crashed so hard we had to do him. So, yeah, what they do, get high, right? All right, so, psychotic conditions due to medical conditions and other modifiers, if you will, brain tumors, seizure disorders. Who's seen the movie The Green Mile? Everybody? Huh? It's a great movie, right? Oh, yeah. So the lady had the brain tumor. She acted psychotic there for a bit, right? She had a brain tumor, right? So seizure disorders, delirium, Huntington's disease, all these can make you get crazy. MS, Cushing's, which is an adrenal problem, vitamin deficiencies, electrolyte abnormalities, thyroid, uremia, lupus, HIV, Wellbutrin. I never heard of that before, but I guess it can cause problems. Anabolic steroids, get juiced up, corticosteroids, and anti-malaria drugs. All right. Delusional disorder is when you have non-bizarre delusions, right? They're here with you. They're not seeing stuff melting in front of them. They're not hearing stuff. They're not seeing faces, but they have this crazy idea. You know, they gotta take the shot at Ronald Reagan. Didn't he want to impress? He wanted to be with the model. He had a delusional disorder with the model. Ronald Reagan was president in 1984. And he just took a shot, and the guy was a delusion. He thought that he was going to be with him again.
He just got out of jail. You're right. Yeah.
Wow. Okay. That's a little scary. All right. But they have not had the criteria to meet schizophrenia because they haven't had the hallucinations or the loss of the reality. They just have some very bizarre ideas. Okay? Apart from the delusions, they have a job. They, they buy groceries, use solutions. And it's not due to a mood disorder or substance, and it's a very small lifetime prevalence. And you have friends that say stupid stuff. You're delusional. Crazy, right? You use it vernacular all the time. Let's go to Vegas. Yeah, delusional. Crazy. All right. So you can have some subtypes. It could be aromatic, grandiose. I'm all that in a bag of chips. Persecutory. The CIA is after me. Jealous. I know my boyfriend or wife have multiple boyfriends or other partners. Somatic. It might be, I know I have, here's a good one, remember? This 65-year-old lady thought she was pregnant, and she wanted to check to be pregnant, 65. And we looked at her records, her uterus have been out like for 4 years already, you know? She had fibroids. I know I'm pregnant. Check me for pregnancy. What do you do with that? I'm not going to check her. She's crazy. So you say, yeah, you might be pregnant. You don't have a she doesn't care. She's pregnant. But anyway, what I'm trying to get at is she's delusional. No matter what you tell her, no matter what kind of evidence you show her. We show her the records. Look, 1976, you lost your uterus. You had a bunch of fibroids. You were bleeding. You took it out. I'm pregnant. Anyway, okay. Psych? Right. It could be mixed. It could be a cocktail of these stuff. As a provider, these are the type that you can get in trouble with. Always have a second person in the room with you, just to make sure, especially if they're automatic and they're effective. And again, remember, this is probably not the only disorder they have. They're gonna be borderline personality, with some delusions going on. Always protect yourself. Protect your license. Okay. All right. Brief psychotic disorder. Delusional hallucinations or speech serotonin usually lasts less than 1 month. Usually return to premorbid functioning. These are the ones that people go through trauma, and then you sort of, you know, don't want to be around to deal with the trauma. They might dissociate, okay, or they might start forming some stories to sort of deal with the trauma that's going on, okay. But this is what we use most of the time with people that has a variety of symptoms, if you will. This is psychosis non-specific, so people hallucinate and have delusions, and you know they act up, and so you can't really assign them one diagnosis. You get this diagnosis. All right. So major depressive disorder, the psychotic features, leading diagnosis given depressive theme psychosis, depressed mood. Again, no physical explanation for their symptoms. No more physical exam, negative history. But you have to make sure that the patient meets the criteria to be depressed, okay? Suicidal ideation may be present, may not be present, but this definitely will have the psychotic features as well. And of course, you got to rule out there's no other reason for the psychosis. All right. So these people you want to ask about any manic episodes to suggest bipolar disorder. If they are users, you want to investigate that. A lot of this history you will get from past records, you know, because the patient will not be able to tell you a lot about their past history per se, and if they do, they might be making stuff up. So make sure there's no medical issues, and again, does not meet criteria for schizophrenia. They use super depressed, and that's their main issue. Okay, where else? All right. So acknowledge that you believe what they're telling you. If they're telling you, man, I'm seeing the face of Abraham Lincoln behind you, and he's telling me to slice your throat. Believe that. My wife was working during her RN rotation at UNC site, and she went to see this guy, and she goes to the two nurses. My wife goes, how are you doing today? I want to jump up that tower and smash my head. Good job, honey. Well, they'll say that stuff, very matter of fact, with no emotion. I want to slash your throat, or I want to kill myself. They're very, very blunt. Try not to collude with the patient. How about the movie Patch Adams? Patch Adams? It's a great movie. In the beginning, he was in the crazy house with a roommate, and the roommate was seeing squirrels, right? So they put the bed down, and they were shooting squirrels. And Patch Adams said, yeah, shoot the squirrels, right? Don't do that, okay? But I used to try to calm them down, so use your judgment. I mean, you definitely don't want to feed to their delusion, but if he's going to get you to say, well, what color are the eyes of everybody? Oh, they're red. Okay, what's he wearing? You know, try to get him to calm down and look at it that way. Okay. So, what I'm trying not to collude, try not to add to their drama, if you will. Try to establish rapport before confronting psychotic beliefs. Okay. And don't be overly friendly if you can feed to the paranoia. Okay. Always be professional. Keep yourself in the middle emotionally. Okay. All right. Psychotic disorders can be primary or secondary, right? Cornerstone of treatment is antipsychotics. Kind of get them, kind of snap them out of that. The secondary psychotic illness is treat the underlying cause, and you will still need antipsychotics. So it's a major depressive disorder. Treat the depression, because that's probably going to help you treat the psychosis as well. And there are approaches that we outlined earlier. And I think, did you guys get the behavioral health study guide that I posted there? There's some things that I can also help you on this. All right. All right.
In this interview, the psychiatrist interviews Jo. She is a young woman with schizophrenia who is currently experiencing haptic hallucinations. a form of tactile hallucination which is sexual in nature and paired with delusional elaboration. Additionally, she has persecutory delusions of reference. There's a depressive element to her presentation, and guilt is evident. It is not clear from the interview whether this is held with delusional intensity, or whether her depressive symptoms meet criteria for a mood disorder.
Good morning, Joe. How are you at the moment?
Well, I'm not good. I'm not good.
No.
No.
What's troubling you?
I start... People keep looking at me.
Yeah.
They know what I'm thinking. They're thinking I'm disgusting.
Why would they think that?
Because they can see what's going on. No, they know what I'm... They know how I'm feeling.
How do they know what you're feeling?
They're laughing at me.
Okay.
Oops, sorry guys. I'm trying to make it less. Alright, okay. Alright.
In this depressive symptoms meet criteria for a mood disorder.
Good morning, Joe.
Sorry guys.
How are you at the moment?
Well, I'm not good. I'm not good.
No.
No.
What's troubling you?
I start... People keep looking at me.
Yeah.
They know what I'm thinking. They're thinking I'm disgusting.
Why would they think that?
Because they can see what's going on. No, they know what I'm... They know how I'm feeling.
How do they know what you're feeling?
They're laughing at me.
Okay.
I can see them. They're looking at me, and they're laughing at me, and they're all talking about me, and they all know what I am.
Who is it that's talking about you and laughing about
School.
you? This is the new job that you started.
Yeah.
You mentioned that they know what you are.
They know I'm a paedophile.
Right. What makes you say that?
They can see inside my head, and they know what I'm thinking, and they know about the... They know I'm disgusting, and they know about the feelings that I'm having.
What feelings are those?
Like there's something there.
Can you explain a bit more?
Like there's something there, like I'm having sex. Like...
Right. A physical feeling there. Yes. Is that there all the time?
Not all the time, just... But they know.
Yeah. About this sensation. How real does that feel? Does it feel like you?
Oh,
you
it's
are?
real.
It is real.
There's something there.
Okay. Have you seen anything there? Is any...
I can't see anything. I can't see anything. But if there is something there, I know there's something there.
How can you account for that sensation if there's not actually anything there?
Because I can feel it.
Right. Is there anything else strange that you can feel?
I can feel that there's something there, and they can see it. They know how disgusting I am.
Right.
And they're laughing at me. And they're looking at me all the time and laughing and talking. I can hear them.
Do you ever have any sort of unusual other sensations, like hearing things that other people wouldn't, or seeing things that aren't there?
No. I can just feel that there's...
Yes. And these people who know how you feel,
Can they read your mind, or do
They
you
know what's going on in my mind. They can tell. They look at me and they know what I'm thinking.
Do you think maybe it could be that they're just, glancing your way or looking in a different direction?
No, they're looking at me and they know what's going on and they know that I'm disgusting.
Has anybody else commented that other people are looking at you, or that actually said to you that you're disgusting?
They don't need to say. I know what they can see inside my mind and they know what I'm feeling.
Do you ever get the feeling that your thoughts are sort of known to everyone, that they're being sort of broadcast or projected out of your mind?
I don't know.
You're not sure?
No.
Okay. What about people inserting thoughts into your mind? Or taking thoughts out?
I don't think so.
No. Okay. Do you think you're in control of your own thoughts?
Yeah, I just think they can just see what I'm thinking.
Are you in control of your own body? Or do you feel that somebody else may be moving parts of you or causing these unusual sensations?
I feel as if there's something there that somebody's put there that's making me feel like I have these feelings.
Okay. Now you've had these feelings before, haven't you, Jo?
Mm-hmm.
Right. Remind me, when did they first begin?
When I was at university, when I was at university first, when I was doing medicine, and it was I was trying to get to know this boy. Well, this boy was trying to get to know me, and he was trying to get inside me, and that's when it all sort of started. And
Do you mean he was trying to have sex with you?
I think he wanted to.
Okay. And were you under a lot of stress, do you think, at that time?
I was taking my exams. Well, I was going to take my exams, but I didn't take them because I wasn't very well, so I came home.
Right. And you got quite suspicious then as well, didn't you, that people were thinking the worst of you?
Yeah, I'm useless. I'm no good for anything, and I'll never get a job, and I'm just hopeless, and everyone's better than me. And I thought that then too, and that's why I left.
Yeah. Okay. Because you've tried different courses, and each time you try a course to go back to work, it kind of upsets you, doesn't it? Yeah.
Mm-hmm.
Okay, that must be quite disappointing and upsetting for you.
Yeah, it is.
How is your mood at the moment?
It's been better. I feel awful.
Yeah. Have you got much energy?
I know there's something wrong with me. I just want to be better.
Yeah. You look quite down.
Yeah. I'm alright.
Are you keeping interested in things? Is there anything that you find enjoyment in?
I can't really do anything. There's nothing really for me to do.
What about your energy levels? You tired all the time? How about your sleep?
Don't know really.
Okay. Are you concentrating? Able to pay attention to things?
I was doing alright. And then when I got the job in the school, I was doing alright in the charity shop. Because I was working in a charity shop a couple of mornings. And things seemed to be going quite well. And then I got the job in the school, and that was 2 weeks ago, and they just look at me. It's just the way they look at me.
Yes. Well, I can see that it's preying on your mind. I'm just wondering what other impact that's had on you. Are you able to get out and about and mix with people?
No, because they're all looking at me and they all know how disgusting I am, and they all know. I know they can see what I'm thinking, and I know that they're thinking. I know that they know what's going on. Do you know what I mean?
Alrighty. So let's spend 10 minutes in your group, and I guess we'll split up. Let's do mustaches, appearance and speech, and then we'll do beats. Beats, motor, mood, and then Bubbles, thoughts and perceptions. Okay? And then this is a good one. You need marker? Here's a couple. You need a marker?
Got yellow. Is it gonna work?
You can go to one of the study rooms.
Yeah.
The study rooms have markers too.
Mary Heather was hogging them all. Yeah, she was.
Is that working okay? Is that working okay?
It works, but you can't really see it.
There you go.
Alright, what are we doing? I'm out of this one now.
All right. Here we go. Let's do. It's a cooperative, right?
No, that's right.
Again, spelling. Yeah, what did I write? That's nice.
My bad.
They all seem to just quiet and reserved. Paranoid? Paranoia? Is that under?
That'd be mood.
That'd be movement.
And maybe thoughts and perceptions.
Yeah. She's kind of witchy?
Yeah,
I'm thinking.
She looked around the room. That usually was when she was talking about something. Which makes sense. So it was when she was talking about something particularly embarrassing, she would kind of look away.
So she wouldn't make eye contact.
It makes it really
She did it, she just didn't. I wouldn't say it was appropriate. She didn't make it appropriate.
Minimally avoid her.
Avoid eye contact.
I guess it was like
They called it aversion.
I like that one.
They call it aversion.
I misspelled everything right.
You know what?
I did.
I didn't even know yet.
Awesome. I appreciate it. Huh? It wasn't like swearing or like, you know, mild mannered. Mild mannered. Yeah. It wasn't aggressive, like, it was like
Mary, you good?
Oh, yeah, sure.
All right. All right, listen up. All right, guys, listen. So what was her primary problem, depression or psychosis? What's her primary problem, you think? Right? Could it be like major depression with psychotic stuff? Right? Pretty could be, right? So who had appearance and speech?
that would be us.
All right, let's hear it.
Okay, so she was appropriately dressed and groomed. She was cooperative with the interviewer. She was quiet and reserved, withdrawn. She had very repetitive speech and language. Kind of kept on saying the same phrases over and over. She seemed very embarrassed by what she said. She was she had like poor eye contact, and really averting, kind of like physically addressing the person. She was very anxious. She had simplistic speech, and she was mild-mannered. She wasn't aggressive or anything. She wasn't accusatory or anything like that.
To me, it seemed to be that it's almost like pulling teeth out of her to get her to kind of. She really want to talk about what, you know. Tell me how that feels. Tell me how that's been going on. She wasn't very forthcoming, right? Right. Good job. Motor and mood. Was that you? Motor and mood. Okay.
That's us.
Yeah.
So we said she was depressing and kind of meek in her demeanor. She was acting fidgety, very anxious because talking about things was like making her seem to be more anxious. She didn't have very good self-esteem, kind of low. She just knew everybody thought she was disgusting and very hopeless. Didn't really have any kind of hope as to what she was going to do about it, and she felt pretty useless.
Right. And he used some screening questions for depression, which were what? What was depression? Lack of energy. What else? Pleasure in doing. Right. So you kind of went that route. Let's see how depressed you are. All right. Anything else, Mary? All right. Thoughts, perceptions.
Well, she thought she was disgusting. So someone brought up, it kind of seemed like she was perceiving that there was something in her vagina and people knew it, and that they were thinking that she was disgusting because of it. So Raleigh pointed out, and someone else did too, that maybe she was sexually assaulted because she was talking about that guy in college, and that maybe her feelings and thoughts kind of stemmed from that traumatic experience.
Which would lead to another
PTSD. So
is that cocktail?
I thought that was really
Yes, good pickup.
yeah. And then she obviously thought that people could see into her brain and knew her thoughts.
Right.
And she also was perceiving herself like super negatively. She was blaming herself, and she said, "I need to do better," feeling guilty. So kind of like taking that kind of victim blame mentality.
And I didn't catch any mention of hearing voices or seeing stuff. I didn't catch that, so she's not
No, she seemed just more.
You catch it?
Well, they said that she had maybe had to take her to the hospital tactile hallucination.
Oh, you're right, yeah. Because she probably has some tactile. She felt. Maybe that's some tactile. All right, so you guys see kind of where Brett and I were just discussing. I think it's more depression than psychosis. You go, well, I think she's more psychotic than depression, so you could argue it both ways. But I think at the root, like Dory implied, I think the PTSD is probably.
That was Raleigh.
Raleigh.
Silence over here.
Remember this format? Okay, when when you write your psych note, okay, and next year when you do your psych note for next year, you will do an HPI, like a regular HPI like you do, plus you will do this. So they notice like 3 pages long. Yes.
Yeah.
So what you do is you have an HPI, medical stuff, and then you go to psych. Yes.
So it's a or a spoke? Like a spoke. Sounds like a spoke.
You're a cutter.
Spoke.
Yes.
Spoke.
I'll post a note so you can see how you open it. What? You don't have time for that. Remember, this is All right, guys, listen, that's the last time we're going to do this. First year, thank you for participating on the thing here. I think it's going to help you. It's okay, take your ball. When you do the write-up for your altitude on Friday, just write this. Okay? Appearance, vision was blah, 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 more blah, blah, okay? Just a little one-pager, okay? So you have to write the whole physical exam. You won't have to do the full physical exam. Okay? But just exercise each muscle on Friday. Capiche? Capiche. All right, see ya. Go boat. Go boat.
Don't worry about me.
Thank you. I appreciate you putting up with me.